Hello. Ooh, the hair's sticking up a little bit. Work with me, folks. Okay, there we go. Hello, hello. How's everyone doing? Thank you so much, and welcome to the Ask the Experts Wednesday live stream. So, as you notice, oh, geez, the hair. All right, there we go. We just showered, and the hair's arguing with us. Okay, perfect. All right, everyone. So, welcome, welcome, welcome to the International OCD Foundation's live stream content. So, today is Wednesday, December 7th. 9 a.m. here on the West Coast. I know it's noon out there on the East Coast, folks. We have a lot of international folks that join us for our live stream. So, geez, okay, there we go. A lot of international folks that join us for the live stream. So I have no clue what time. It's usually like 8 or 9 hours over there. So right now, you just see me. Usually I host this with Liz McAdell, who's one of the IOCDF's national advocates, as well as the director of the Houston OCD McLean Residential Treatment Center in Houston, Texas. And she may be joining us a little bit later. She's dealing with some personal stuff, so she may join us a little bit later, or it may just be me. I'm not sure. But first of all, what I always like to ask people to do is in the comments, go ahead and tell us where you're from. Where are you tuning in from? What location? I always like to hear from everywhere that people are joining us internationally or in different parts of the country or in my hometown. So it's always exciting. And then I love to hear who you're here to support. Do you have OCD yourself? Do you have a related disorder such as skin picking, hoarding, or BDD? Are you here to support your husband, your wife, your friends, your cousins? Who are you here to get information from? So I always like to hear it. We already have some shout outs. So hi to Jessica in Moscow. Welcome, welcome. We also have Carrie. I butchered that, in Houston. So awesome, Carrie. I'm sure it's Carrie. I'm sorry. In Houston, Texas. Awesome, awesome. Welcome for you're another warm state. Everybody keeps yelling at me that I'm getting like the warm temperature, and so Texas and Florida and other states. Victoria, welcome, welcome from Long Island. My mom was raised in Long Island, so she was in Levittown. So anyways, welcome. So thank you everybody for joining us. Hi, Matt. Nice to see you. Hi, White, out there in Washington, and you're here for your 19-year-old son. That's awesome. It reminds me of my mom supporting me when I was around 19, 20, 21, looking for treatment. We have Ray in New Jersey. We have Bonnie in Sherman Oaks out here by me, tuning in from LinkedIn. Welcome. We have a 16-year-old daughter, Carrie, supporting. We have Matt from the UK. I want to travel so bad. Every time I do these live streams and I hear where everybody's from, I'm always so jealous. I'm like, I want to travel. So just a little bit about the live stream. So we always have people calling and emailing the IOCDF asking a bunch of treatment related questions. And we thought, we've had live streams, we were doing themes each week, but we thought that so many people just wanted to ask general questions. And that's really what the live stream is all about, is to give you an opportunity to ask myself and Liz questions from anything about the OCD treatment journey, any questions you have about thoughts and feelings and sensations and what to do. So we both have OCD and we answer from a lived experience, but both of us are licensed clinicians. She's licensed in Texas, I'm licensed here in California. And we're here to give you clinical direction, information, education. So the Wednesday at 9 a.m., 12 Eastern live streams titled Ask the Experts are just that, an opportunity for you to come in, chat with other people in the comments, tell everybody where you're from. A lot of times people are answering each other's questions. It's beautiful to see across different platforms. A little bit about myself. So I have OCD. I was fortunate enough, after extremely severe debilitating OCD, to find the International OCD Foundation, who led me to a treatment provider, Karen Pickett in Los Angeles. I was able to get treatment for OCD and really manage it and get to a point where now I'm in recovery, which means that a majority, if not all of my life decisions are made out of values and things that matter and not based out of OCD. I wanted to give back, so I turned around and became an advocate for the International OCD Foundation, and now I'm one of their lead advocates. I'm also on the board of directors, and I'm a therapist. I kind of came full circle, and so I've been treating OCD at the Gateway Institute in Orange County, California here since 2009 is when I got hired, but 2010, but then really working with clients since 2015. So I'm here to answer your questions and support you in any way that you can. So a couple things. The way that you can ask questions is just in the chat. Ask any question, anything you're interested in that's OC and related. The only thing is I can give general information on medication. I can't give specifics, but we are in January. One of our first Ask the Experts, we're going to have a psychiatrist on to answer medication-specific questions. But ask anything. We do have pre-submitted questions, so I'll be kind of going back and forth, but I like to prioritize the live ones for those who are joining us. So definitely ask your questions about anything in the chat or any comments or any feelings you're having. I'll comment on that as well. Just quickly before we jump in, is this live stream is educational and it's not intended to replace therapy. So if you have treatment related questions that you really need to go in depth with and get help with, that's where you want to find a provider or contact a local clinician. You can always use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. The IOCDF is not a crisis hotline. So if you're in a crisis or you're feeling suicidal or unsafe, please go to your local emergency room or call 911. Or we now have the 988 Suicide and Crisis Lifeline. You can dial 988 or go to 988lifeline.org. Lastly, we want to create a safe space and be kind and respectful to everyone. At the end of the day, we're all here to support one another. This is being broadcast on several media platforms and is being recorded. All right, so I have my pre-submitted questions up, but I want to also acknowledge a couple more people that came into the chat. We have Jessica, who's from Brazil and now in Moscow. So you're from both. Oh, wow. I'm jealous. I really want to go to Brazil, except I don't know Portuguese. I know some Spanish. So I kind of get butchered out there in the language. And it seems like you're struggling. You're in the right place. We have Dlias, 13, who's an amazing person from YouTube. We have Victoria's doing her 18-year-old son is why she's here to support. We have Stacey from Pennsylvania. Awesome, awesome. All right, let's jump into the first question. It's at 12:04 your time, Amanda. I would like to know your thoughts on how OCD is correlated with intelligence, namely creativity and emotional overexcitability, intensity. Also, what are your thoughts on triggers occurring at similar times? Okay, it was part of the next question. So I can definitely speak on the overexcitability around emotions and intensity. So when I did my thesis in graduate school, some of the research that I found is that individuals with OCD have more difficulty with emotional regulation. So what does that mean? If normal people's emotions are like this, people with OCD's emotions are like this, much more intense emotions. So really high highs and really low lows. And I'm not surprised because part of the brain, the limbic system, and the amygdala is what OCD affects. So those parts of the brain deal with anger, deal with frustration, with fear, with emotions. And so we have an overexcited and overactive amygdala constantly telling our brain that we're in danger when we're not. That's why little things that other people can kind of just shrug off are able to just move on with their day. We can't. It sticks with us. It repeats. It gets very cyclical. And because of that heightened emotion, we misread those intense emotions as we're actually in danger. So that's absolutely part of the treatment, is to learn to read your emotions and to find out, how does OCD manipulate my emotions to trick me into giving into things? Because what you have to remember is we're collecting data with our mental and physical compulsions to try to determine if we're safe. And if one of the ways that we determine our safety is looking at our emotions, if we're always being tricked because our emotions are all over the place, we're going to react. So one technique, there's multiple, is to never respond to OCD in that heightened state of alarm. So if I just walked into a grocery store and somebody walked by me and I think I saw blood on them and I'm worried about getting a borne illness, if I immediately react because I'm feeling that intense emotion, I'm going to make a bunch of compulsive decisions not aligned with values. I'm going to leave the grocery store, go home and shower. But if instead I stay at the store, I continue to shop, I really focus on that, I don't engage in the conversation my brain wants, my anxiety will start to wane a little bit and then clarity will pop through. So what we have to recognize is the good thing is what the research also showed in my thesis is that when we do decide to do the treatment, it helps regulate our emotions. Medication can as well. And so I know now I don't respond as emotionally intense to my triggers as I once did. The other part of your question is triggers occurring at the same time. That can absolutely happen. So an example from my own life, because it's easier for me to do that than clients because of HIPAA and everything, is like I could be at a grocery store and I had fears of like chemicals. So I could be at the grocery store and somebody walks by me and they're holding a can of Raid and kind of like looking at the label. And I could also have intrusive thoughts of physically harming a stranger, like walking by me in the aisle at the same time. So it's difficult because you're kind of getting hit from both directions. That's why I believe part of the treatment that's super important is to learn how to not respond to everything and start to realize that content doesn't matter after a while. In the beginning, it does because you have to really identify what are your triggers. Your therapist have to create a plan. But over time, what you want to learn how to do is to recognize that all of the OCD lies are the same. It just sounds the same on the surface, but underneath it's trying to tell you that you're in danger and to respond. So if I was in that store and both of those things were happening simultaneously, I wouldn't get out of the aisle to run from the danger, right? I would lean in, I would really kind of walk by the person who has the chemical and kind of keep shopping and buying items. I'd say hi to the person my brain says I'm going to attack. And even if I felt like my skin was falling off, I'd stick in that aisle and push through, because you learn something from treatment. And I'd start to learn that, there is no danger. And then lastly, I do know that when I've gone to talks, I haven't personally studied this, but when I've gone to talks at the conferences, some of the researchers have talked about people with OCD having higher levels of intelligence. I'm not surprised. All my clients are brilliant. Oh, you have to be smart to have OCD because it causes us to use so much brain power. So that's the one good thing, is that we are very smart people and determined people. But I always tell people, once you get better from the treatment, your intelligence and your determination doesn't go away. So that's something. I hope that helps. All right, we have a question at 12:06 from Jessica. Sorry, my callers are always falling. I have a hard time dealing with that rather strong feeling that just because it's happening again, that must mean that the content of my thoughts is undebatably true. How can I navigate that? So the hard thing with OCD is that not only does it come with thoughts, and I try to explain this to people that don't have OCD, is that it's not only thoughts. It brings along, it's kind of like sidekick, which is emotions. So that's what's difficult, is that strong feeling that it's happening again, it's repeating, this is constant, this must be important. You're going to get those thoughts and you're going to get those feelings. And that's why OCD is cyclical. It really focuses on similar themes for a while. Now, people can have multiple themes, of course, but for instance, if you're constantly worried that you're not locking your doors when you leave your house and you're getting, feeling guilty, I have family members and roommates, and what if they get attacked? Just because we have that thought consistently every time we leave the house doesn't mean it's more likely to be true. That's something that we know is like, thought action fusion. Simply because I have a thought, it must mean that the action coincides. So if I'm having more and more thoughts about the idea that I didn't leave the door locked, it must mean that this is really true. So what we have to recognize is that just because we have that same repetitive thought each day doesn't mean it's true. It feels true because if we keep doing the compulsion, that reinforces the thought and keeps it going. So I've worked with clients that have had OCD, the same intrusive thought, for 30 years, 40 years. And they're saying, Chris, can't there be some reason that I'm having this thought? It must mean maybe it deals with my subconscious, or it must be more likely to be true because it keeps popping up. No. You keep doing the compulsions, and the compulsions are basically telling your rational brain, this is important. This is something you're doing for safety. You have to keep doing it. You have to keep being safe. And so what we have to realize is if we stop the compulsions, what everybody will notice is that thought stops coming up. So if I'm in my house and I'm saying, look, I have been checking over and over my locks. Nothing bad has ever happened. I've been doing that for 10 years. Nothing bad has ever happened. I have no proof or evidence that this could ever occur. It's simply just the doubting disorder. So starting today, I'm going to lock the door once and walk out and not look back. And I'm going to be consistent. After doing that for 2, 3, 4 weeks, you'll notice that urge and those thoughts will start to fade. And because those urges and those thoughts start to fade, you won't feel like it's as real, and you'll be able to move on. So definitely trust that the treatment works. The next question is from Ray at 12:06. Generally speaking, was medication a part of your recovery journey? And if so, was it helpful? I know it affects everyone differently. Great question, Ray. So Ray, for the first beginning of my treatment, I refused medication. I think for 2 reasons. One, my mom is a registered dietitian. We've always been like a healthy family, and she wasn't anti-medication, but just growing up, my mom was like, only take Advil if you have a headache, or, she just wasn't, we just weren't somebody that always took medications, I think. I don't know why, to be honest, but so when I went in, I already kind of had that stigma, but my OCD attacked it. I was wondering, I had contamination. How was I going to take a pill and put it in my mouth? I also had fears that the medication would change me and make me erratic, and I'd hurt someone and be out of control. So I had a lot of misinformation. And that's what we have to realize with OCD is our brains just make up facts and we believe it and never really challenge it. And so I went into treatment and didn't do medication the first 6 months, and I made a lot of progress. However, after that 6-month period, I pretty much plateaued. It didn't matter what we did in session, how hard I worked, nothing changed. And my therapist and I were so confused because we're like, Chris, you've done the treatment and it's worked. What's happening? So I admitted to her that even though I had been seeing a psychiatrist, I hadn't been taking the medication. So what really helped me is I went to a psychiatrist that was really well versed in OCD. He worked at the UCLA OCD treatment center. He had been studying medication. He really knew the disorder. And I went in open-minded, not judgmental, just open-minded. And I just listened. And I told him, I'm not sold today. I just want to listen. I want to make a choice after I leave here. And I asked my questions. And I think what really helped me is that these are medications, SSRIs, which are the first line of treatment, selective serotonin reuptake inhibitors. These medications, if you go off of the medication, any side effect you feel will fade. It's not something where people have permanent damage from taking medication. So I decided to give it a try. And what the medication did for me is it made the thoughts less frequent, less loud, and it was a lot easier to do the treatment and a lot easier to dismiss the thoughts. So I personally went on Prozac. I ended up going up to 80 milligrams. Once again, just like you said in the chat, it affects everyone differently. So this was my decision with a trained professional. So please don't do what I did simply because I did it. The reason I went on Prozac is because my family, I had a couple people on Prozac and they handled it well. So they decided to start there. With that medication in my system, it allowed me to then really complete the treatment. I stayed on medication for about 2 years after treatment just to keep, because I went from housebound to life, and so I was learning new things doing treatment, and the medication stayed in my system. When it was time to taper down, because it was about a year of no symptoms, we tapered down very slowly. I'm not on medication today. I haven't been on it for over a decade. I have no stigma around it. If suddenly, hopefully not, but if suddenly for whatever reason, I could never imagine myself having a huge relapse. It's just been too long. But if I did, I would never reduce or take medication off the table. I would find a trained professional and work with them. So I would definitely, Ray, just meet with someone. That's what I tell everybody is just meet with someone. Don't go in with expectations and just bring questions and really feel it out. And the good thing is if they write you a script, it lasts, at least in California, for a year. So you don't have to like get on it right away. And just try it, give it a little bit of time. You can go slowly. So I hope that really, really helps. All right, GH at 1206 asks, what's the role of motivational interviewing in therapy, especially with helping ERP? How would you use it? So awesome question. I'm actually going to, I promise I'm not like texting a friend. I am looking up online. There is a really good government study for this topic. So for motivational interviewing, for those, I'm so bad at doing two things at once. So hold on, motivational interviewing for OCD. Yes, here's the government study. So that means that it's free. So I'm going to put the link in the private chat for the IOCF staff, and they can go ahead and put that up. Okay, perfect. Sorry, I'm so bad at doing two things at once. All right, so this study actually talks about how motivational interviewing can help. So those of you that are not familiar with motivational interviewing, it's by a gentleman named Meyer. There's actually a good book on it, and it was originally created for individuals with addiction, so substance use disorders, because there is sometimes a really hard buy-in. And motivational interviewing is a technique of not like threatening someone to get treatment or not pushing someone to get treatment. It's the person with OCD finding value in the treatment and seeing why it would matter to them. So I absolutely use this. So I work with a lot of teen and young adults. I work with all ranges. I've worked from 6 to, I think, 86. I notice sometimes my teens and young adults are a little bit less willing to get treatment. And I believe it's because everything hasn't fallen through the cracks yet. You still have your parents helping to support you. Teachers are usually working with you at school. There's a lot of flexibility. So I have a lot of clients that come in and they're not ready to do any kind of treatment, ERP, or even hear it. And so emotional interviewing is a bunch of different steps. So there's a great book on it. The article talks about it. And what I really do is I work with the client before we even start ERP, before we even start the education on OCD. The way that I would use motivational interviewing is really asking the person, like, what kind of life do they really want? What would be the value in doing treatment? What would that look like if they were to do treatment? How would their life shift? What are the things that they're really important to them? And examples, I was working with a teen fresh, newly in high school, and had gone to multiple treatment providers and was not willing to do the treatment. So I just used motivational interviewing and found that the thing that he misses the most is playing online video games with his friends, but he can't do it because of so many compulsions. It takes him an hour just to get on. So all I did in treatment is focused on getting him back to play online video games. That was something that mattered to him. So he was willing to do it. So we spent all of treatment getting him online and playing video games. And once that happened, he's like, wow, I guess the treatment does work. And it's not as bad as everybody says. I think that's the problem is ERP gets a bad rap and people think it's like fear factor, and it's not. It's really teaching your brain that what it's telling you in those moments with OCD is false, and that we can push through and live a value-based life. So once he saw the treatment worked, he was willing to do it for other areas and get better. So hopefully that article helps, and hopefully that's something that is helpful. All right, so we have our next question at 12:07 from Matt B. I have a question about visual tourette and staring OCD. Is there more research for this subtype OCD, as I'm trying to find the right treatment? I've been struggling with this for 6 months. So a couple of things out the gate, Matt. I'm going to have Amanda on the back end put up a link to a live stream. It was with John Grayson. So he actually did a whole live stream on this, on OCD around staring. And there's also, I believe, have been some live streams about visual Tourettic kind of staring OCD. Articles that he's done as well. So we have it as one of the IOCDF live streams. I actually dealt with this. It was really embarrassing. I would find myself getting stuck at staring at like inappropriate areas on people. And so it's really, really difficult. So I know it's a newer topic that John Grayson has been talking about. I would definitely check out that live stream. I know that he's written an article about it. It's so hard for me to Google and talk to you guys at the same time. So I if they can find it on the back end, or we can always look over it and then next live stream put it up. But what worked for me, I'll just tell you what worked for me, because I had this type, is my brain was always like, don't stare there, don't stare there, don't stare there, because I would stare at inappropriate areas on people and I didn't want to. I stopped fighting it. And it sounds crazy, right? It sounds like if I stop fighting it, then I'm absolutely going to do it. But it's just like a teenager. If all of you parents have teenagers, I don't have a teenager, but my youngest sister is 10 years younger, and I kind of helped raise her during her teen years. Whatever you tell a teenager, they'll do the opposite. So you use kind of like reverse psychology with them. Oh yeah, no, if you want to stay out all night, no worries. It's not exciting anymore, and they don't, sneak out. It was kind of the same thing for me. It's like, well, today you're just going to be staring, and inevitably someone's going to be offended and you're going to get arrested or attacked. And then when it wasn't taboo in my brain, I found that it didn't care as much to check. I was sort of just walking and I would forget about it. And that wasn't a subtype I struggled with majorly, but I did struggle with it, especially after being housebound and going out with people for some reason. So when I stopped fighting it, my brain didn't find it as interesting or taboo. Think of it as like driving on the freeway and you see a car accident, you're drawn to it. That's how it worked for me, because it was staring at certain places inappropriate on people. So when I'd walk by them, it was like a car accident to my brain, and I'd find myself just looking and not even almost recognizing it at times until it was too late, or people would kind of make a comment. It happened twice. It was thoroughly embarrassing. So hopefully that helps, and that live stream will jump into it a little bit deeper. Hi, Betsy from PA. So good to see you. Melissa at 12:08 says, hi, Chris. Hi, Melissa. My 19-year-old daughter has been doing ERP for years. We got a second assessment, which identified that panic disorder interfered with OCD treatment. How to treat panic with OCD. So a couple things. The good thing is, if you are on medication for OCD, the medication for panic disorder is the same. Sometimes people use a benzodiazepine for panic disorder in those moments that they're very anxious. But once again, we're going to get a psychiatrist on to really help answer those medication-specific questions. So awesome. We'll definitely do that to answer more on the medication side. On the panic side, the good news is that there is some correlation between the treatment. So in panic disorder, what that is that somebody's had a panic attack and the experience was so difficult for them and so overwhelming that now they fear having another panic attack, and they find themselves just like OCD, fearful of going to certain places that might trigger it. I've had clients not want to work out at the gym because it gets their heart rate up and it reminds them of the panic attack they had. I've had clients where their panic attack was in the morning or in the middle of the night, so then they're afraid to sleep or they don't like waking up. What I've noticed about panic disorders, it's a lot less mental. For most people, it's a lot more physical. They feel sensations, they feel anxiety, and then that's when the worry or the concern comes in that they're going to have panic. So what you want to recognize is that just like OCD, our brains are kind of self-creating that danger. Because for most clients, when I've asked them about that initial panic attack, there's certain circumstances that happened that led to it, and they've avoided it like the plague, but they're still worried about it. So, I had a client that had a really bad panic attack because he was overusing alcohol, and he was out at a club. It was really packed. It was hot. People were kind of falling on him because it was too overcrowded, and he had a panic attack. Now he's worried about having that again, but he's not drinking. He's not going to clubs. He's not recreating that. So just like OCD, what we want to do is recognize where are the places or things people are avoid doing. Also, what is kind of that mental conversation that the brain is having? So, your daughter, is she constantly worried? Is she checking her breath, her heart rate? All of those things build this story in our head that something bad is inevitably going to happen. When you're having a panic attack, there's different techniques you can use. What worked for me is fresh air. So, I used to have panic attacks on planes or in restaurants or any place that was a little bit like I felt like I didn't have an escape plan. So for me, I would walk out, I'd tell my friends, oh, I'm going to the restroom. I'd go to the restroom and run some cold water on my wrist. I'd kind of walk around because movement or exercise helped me because it kind of regulated my breathing. Fresh air kind of cooled me down. And when I learned that I had techniques that I could use when I was having a panic attack, then when the brain was like, you might have a panic attack, it's like, I know they suck. I hate them. I don't like having them, but I've proven that I know what I can do in the moment, and I'm not going to be checking my heart rate or anything like that. So if in this case the panic attacks is causing your daughter to not want to do ERP because she's worried about the anxiety from the ERP and she's afraid of having a panic attack, then absolutely work with someone specifically on that panic attack, panic disorder, so that she can get to a point that then she feels encouraged that she has techniques. There's a type of treatment called dialectical behavioral therapy, or DBT. There's a lot of good regulating tools in that. There's also in panic disorder, there's called introspective exposures. So that might be like having somebody recreate the feelings of a panic attack, like spinning in a chair, breathing through a straw, things like that. And so that can kind of recreate some of the symptoms, and then practicing not responding, similar to ERP. So there is a lot of tools out there. So definitely work with them. Most therapists, like myself, work with panic disorder and also OCD. But if you're finding the OCD therapist isn't, then I would definitely see if you could find a therapist that can work with both and have them correspond. Carrie asked, can one live without the amygdala? We actually have two. They're the size of almond in our brain. And I'm not a brain surgeon, but I think if we took that out, you might die. Or the other thing is, I know it sounds great. Like there's if anybody watches comics, there's a Daredevil, and he doesn't have any fear. Maybe I think his amygdala was damaged or something. But in real life, people that don't have fear, I think it's not very common. I think it's called like anhedonia or something like that. Learned about in grad school. Those people usually die very young because they'll walk in front of a car or they'll burn themselves on a stove or things like that. So we want to have fear, right? Like if we're driving our car and a car almost hits us, we want to be able to swerve and be safe. If we're walking at night and we hear footsteps behind us and somebody's shady, we want to be able to run to public. So the amygdala is our friend. Carrie, you're hilarious asking for a friend. It's our friend. It's just OCD abuses it. That's what sucks. Like OCD takes these the amygdala is perfect. We need our fight or flight. It's so great for us. And it sucks that this disorder is so insidious and then uses stuff like that and abuses it and then makes it worse. So I hate it. I hate it. I hate it. Sean Coffey, welcome. So Sean asks at 12:12, I'm here to learn ways to deal with BDD. So if you don't know, Sean knows, but BDD is body dysmorphic disorder. It's an OCD related disorder. So OCD has a couple friends with it. It's hoarding disorder, skin picking, hair pulling, body dysmorphic disorder. So body dysmorphic disorder has some similarities to OCD, but the main idea of it is that people have a perception when they look in the mirror that they have a flaw, typically the neck up, but it can be on the whole body, or flaws that look deformed. And they're so unsightly that people with BDD often camouflage, want plastic surgery, isolate, or don't go out. So the treatment has some similarities. So we do want to do a little bit of ERP. We want to practice going to the mall or going in public places and reducing our camouflaging. It's also a lot of more cognitive behavioral therapy than OCD treatment. So it's really identifying what are those beliefs you've created, Sean, because you feel like your appearance doesn't look good. And let's start to challenge those and look like how you got there. And for most of my clients, they're not getting comments from friends or family or, people aren't rejecting them. They just simply have kind of built up in their head based on what they see in the mirror. So another part of the treatment is perceptual retraining, mirror retraining, learning how to look yourself in the mirror the same way other people do. There's a really good YouTube video. I'm going to try to do it. Maybe Amanda, if you could do this, if you go to YouTube and you just type in people with BDD see themselves differently, there's a YouTube video. It's about 7 minutes. I think it's like USA Science or something Science, but it's a really good video out of Australia, out of a lab that did research on people with BDD and found that when they looked in the mirror, they actually see themselves differently than people without BDD. So it really helps explain, Sean, that it's not that you're hideous or you have a flaw or there's something wrong with you. Your brain is wired differently and you use a different part of the brain to see yourself, and you get very fixated on little details. So that video might be helpful. Then also part of the treatment is to deal with, sometimes people with BDD have dealt with bullying or different trauma. So there's a lot of extra treatment on that. So any specific questions you have, Sean, I'd love to answer that as well. Delias right after at 12:13 asks, similar, has there been a relationship between anorexia, BDD, and OCD? Do most people with obsessive concern about body image and being healthy have OCD, or is it nuanced? I would say a lot of my clients with BDD also have OCD. And that individuals with BDD may have anorexia or orthorexia, where they get really obsessed with food. We're actually going to be doing a live stream in February, the last Wednesday of the month. It's going to be a lunch and learn on the correlation between OCD and eating disorders. There's also been 2 live streams on OCD and eating disorders as well, so definitely check those. But yes, there is a lot of crossover. There's a lot of people that focus a lot on body image. So it's definitely one of those things that we see a higher correspondence between those. L. Allen asks at 12:14, do you know of anything about the effectivity of vitamin B1 for OCD? So what I'm going to do is I'm going to take your question at 12:14, and I'm going to swoop down. I have this sheet on the back, and I have a long list of questions for our psychiatrist when they come on next month. Actually, it's probably not even a month from now at this point. It's like a little, almost 3 weeks. Ooh, I just put it in our chat, and I accidentally copied. Okay. That's why you can't do 2 things at once. But long story short, what I'm going to do is I'm going to take your question, L. Allen, and I'm going to put it on our sheet for the psychiatrist. So please join us. I believe that is going to be the first Wednesday in January. They can answer that question better. Also, if you went to the online OCD conference, I was part of a talk that was about overall wellness for mental health. And we had a registered dietitian who answered questions about supplements. I'm not a specialist, but what I can say from the talk is that people do sometimes have positive effects on supplements. It's not going to necessarily change thought patterns. We really see that with an SSRI, but supplements can overall really kind of help with general anxiety and relief, which then makes us more likely to do the treatment. But I will keep that question. I literally just put it on our sheet. So in about 3 weeks, we're going to have a live stream with a psychiatrist, and I'm going to ask all these questions. So please come back for sure. All right, at 12:15, we have Ro Tom, who says, hi, I'm from India. I keep on thinking about whether I did sexually molest a kid or not. I'm not attracted to kids, nor do I want to harm them. I'm totally devastated by the thought. How do I break the loop? So Ro Tom, this is literally the definition of OCD. I myself didn't have OCD around children, but it was around strangers and family members, like sexual intrusive thoughts. All OCD sucks, and having these taboo thoughts is so difficult. So what I first want to tell you, and what I tell all my clients that walk through the door that have these kind of intrusive thoughts, the reason OCD is attacking you is for the reason that you said. OCD goes against our very core and our very nature. You have no interest in attacking children or harming children at all. That's why OCD is attacking you. It attacks the very opposite of who we are at our core. Because if OCD was to say something that was accurate, if OCD said, hey, Chris, you're wearing a blue suit, I wouldn't fight with OCD. I'd be like, yeah, you're right, and move on. But if OCD was to say, Chris, you I don't know, what would OCD say? Like if OCD said, Chris, you're horrible, you might have killed somebody when you were younger, I'm going to get really defensive. I'm going to say I would never have killed someone, and I would remember if I killed someone. How dare you say something like that? And I'd get very defensive. And that's what OCD wants. It wants your emotions to rise, for you to get agitated, for you to argue, for you to try to push the thoughts away. And all of those compulsions feel good in the moment, Rotom. But what it's really doing is OCD is like pushing, pull, push, pull. The more that you push, the more OCD pushes back. And we end up getting to that point that unfortunately it starts to make it feel more real. So that's why OCD is such a trickster, is it thinks like the more I push these thoughts away and deny them, I should get clarity and feel better. The opposite happens. The more you push it away, your brain says, wow, this must be a topic of interest for Rotom. And we get back and forth with arguing. It also sounds like we're having a little bit of like false memory or real event OCD, where it's a past event and it's having you question it. Remember, the more you kind of check in about a past event, the more the details get blurred and the more OCD fills it in. So what I would start with, because it sounds like you're new to this, what I'd really start is to identify what ways do you respond to OCD both mentally and physically on an average day. Are you avoiding kids? Are you not going to parks? Are you not going to toy stores around kids? Are you not going out in the streets when it's busy with kids? We got to change that, right? Like, you deserve to be able to go out in the stores. You deserve to be able to walk around your family and your nieces and nephews. And then on the opposite end, how are you responding to OCD? Are you denying it? Are you arguing with it? Are you trying to ignore it? Are you self-reassuring? Let's reduce that. It's going to feel dangerous to reduce it, but what you'll start to notice if you reduce both of those things I just said, really focus on response prevention, what you'll start to notice is that the thoughts will actually get quieter and you'll get out of the loop. The other thing is, what I love about the treatment is it teaches you to learn how to trust yourself. If you do that and you're noticing that you're in stores and you're around kids and you're not doing anything, you're gaining proof, you're building evidence and building a story against the OCD and being able to say, you know what, I'm starting to trust myself. I've dropped the compulsions, and you threatened me, OCD, that if I dropped those compulsions, that I would immediately start to attack a child, and nothing happened. You're a liar, and I knew it. So hang in there. What you're going through is very, very normal. So please, please, please don't think that you're abnormal or you're a horrible person. OCD loves us to feel guilt and shame that we don't deserve. So I'm seeing a lot of highs. And yes, Leanne, what you resist persists. That's absolutely true. That's what I was talking about. Those thoughts that Rotom was talking about, or the thoughts about harm or whatever intrusive thoughts, what we resist them, our brain bookmarks that and says, ooh, this is dangerous, and persist, persist, persist. Hey, Sean. Oh, you sent me. Okay. Sean, I'm so sorry. I will message you back on Instagram. If you message me, I'm part of one of IOCF's affiliates, and we are doing a big event this Saturday. And I've been so busy with that I didn't check my messages, but I'll definitely check them and I'll get back to you, Sean. But that's a good way to get a hold of me. So I'll definitely message you. I apologize for that. Why don't you message me right now? It's just at my name, and then that way it'll be fresh on top. Hi, L. Allen asks at 12:26, what worked for you while treating contamination OCD? How did you challenge yourself? Great question. So I had a bunch of different contamination. I really hated food contamination, so like pizza, buffalo wings, chips, all of that. It felt very gross on my hands and felt like I was going to spread it everywhere. There wasn't really like a core fear there. I didn't think I was going to die or anything from it. It just felt very gross, and I felt like I'd be anxious forever. I had contamination around chemicals, so that would be like getting an X-ray, using like bug spray, driving by a house being tented. So I afraid that those chemicals would give me cancer. Those were some of my major ones. I had a lot of contamination around my items. I didn't want people in my car or in my room. And so what I had to realize is a couple things, is that my brain was building this story that contamination can spread forever. So I always tell my clients, if I gave you this much blue paint and told you to paint all of my walls, could you do it? And they're like, well, of course not. That's too little. But with contamination, if I touch this much contaminated substance, until I wash my hands, I feel like I could spread it for infinity across everything. So only individuals with OCD have this idea that we could spread a contaminant forever, even if there's only a little amount of that. So with my chips, like greasiness, sure, if I touched a few things, it would get on there. But I can't just keep spreading it until the end of time, right? There's not enough grease on my fingers to keep going. So that was one thing that helped, is recognizing that only my brain would keep track because I had OCD, not because it was really dangerous. Because I'd see my friends and family eating with their hands, wipe with a napkin, and touch things, but they don't have OCD, so it didn't track. What I started with is asking myself, just kind of like I was telling Ro Tom, is like, what are the things that I'm giving up or doing too much of? So I was taking 4 1-hour showers a day. I was brushing my teeth 10 times a day. I was washing my hands 200 times a day. And so a lot of it to start out with was reduction, just cutting back on that. And when I started to cut back on that, you would think that I'd feel even worse. But what I noticed over time is I actually started to feel cleaner. I felt more clean taking 1 15-minute shower than 4 1-hour showers. Why? As you all know, when you're in that shower doing that compulsion, did I forget to wash my hair? Did I miss this part of the body? Like, I was so intense in my head that it prevented me from just living and just like feeling clean and getting out. I was constantly judging my cleaning, and it never felt good enough. So what I started to do is I started to drop those compulsions. Another thing I did is I started going grocery shopping for my cleaning supplies, shampoo, conditioner, body wash, wipes, paper towels during the day, because I would go late at night in the middle of the night at a 24-hour store, so I'd avoid people. So I started deliberately putting myself in situations that normal people without OCD did. And I really practice that response prevention. So what I'd ask you to do, Alan, is to kind of list out like what are the different things you avoid or do too much of because of OCD. Rank them for kind of easiest and hardest. And before you do them, ask yourself, what is the value in this? So for me, I loved going grocery shopping during the day. It is not fun going grocery shopping at like 1 a.m. It just isn't. You feel weird because it's like you're the only one out. It's the middle of the night. You're tired. You should be going to sleep. So I would always see the value in my exposures first and then do it. So trust that you can do it. And as you do the treatment, your brain actually gets quieter and you actually feel more clean. And now I feel a lot more clean. Stacy at 1227 says, yes, going to a quiet place and doing diaphragmatic. I can never say that word. And I've known about that word for 12 years. I'm bad with some words. Doing diaphragmatic, so that's with your diaphragm, so deeper below, breathing during a panic attack helps with panic attacks and grounding techniques. Yes, Stacy, there's a lot of really good techniques, like Stacy's saying, that can help you in those moments. So for me, what I'd even do sometimes is go in my car and blast the air conditioning because I always felt like I was losing air during a panic attack. So the air really helps. So I know with OCD, grounding techniques and box breathing is one that I like, a type of diaphragmatic breathing. Don't always help people with OCD, but it helps with panic. So for sure. Yes, Ray talks about interoceptive exposures. Yes. A lot of good stuff in here. Okay, so Leanne talks about true fearlessness at 1228 doesn't actually exist. There is extremely rare disease. And I'm going to try to say it. Only 400 people have ever been recorded. So, like I said, fearlessness sounds great, but I promise you that you can still get better even if you have some fear. So, hopefully that helps. Okay, so I'm just going through some of the chat. People are saying hi and things like that. So it's great to hear from you all. I'm going to jump into a couple of the pre-submitted questions and then I'll race back into the live questions. So one of the questions that it asks is, BTTI member here. So if you're not familiar with the BTTI is a training institute that the International OCD Foundation does. It's for licensed therapists and it trains them in how to treat OCD. And the faculty is some of the top OCD treatment providers in the world. I have a client with self-harm OCD, so around suicidal thoughts. Do you have extra ideas for early intervention ERP hierarchy exposure ideas? So the question is around people that have intrusive thoughts that they may harm themselves or they may end up attempting suicide, really is what the fear is. And once again, because OCD goes against our belief system, the individual who usually has these intrusive thoughts doesn't want to harm themselves, but they're having intrusive thoughts that they might. And then the mistake that we do, as always, is we do compulsions that OCD asks, which just then makes the thoughts feel more true. So if someone has the belief that they may harm themselves and want to attempt suicide, most likely they're going to find themselves avoiding certain things. Maybe it's knife or sharp objects. Maybe it's high, tall places if they think they're going to do it that way. They might analyze their behavior. Do I feel depressed today or sad or unhappy? They may be triggered if something bad happens, like, ooh, something bad happens. And sometimes people attempt suicide if something bad happens in their lives. There's going to be a lot of that going on. So what we need to do is start to recognize that all of that is just rebranding the OCD as fact instead of false. I'm always trying to remind my clients that OCD always brings you fiction. OCD will never be accurate. So I ask my clients, what are some of the things you're not doing? So if their answer is like, a lot of my clients that have the fear of that they're gonna harm themselves or commit suicide will stay away from high places. So I'll ask them, do you have an upcoming trip? And they'll say, yeah, I do. And I'm like, what if you call them and say you'd prefer a high room? Well, obviously that's going to trigger the client, but I always, once again, like to talk to a client about like, why are we doing this exposure? What are you going to learn from it? Because I don't want people to ever feel like exposures are just me as a therapist torturing them to feel better, right? So I asked them like, why is it that getting a high room would be good? And they might say like, actually in the past, I went to a hotel and they only had high rooms and I found myself not going there and I was driving around and I couldn't find a hotel. So I slept in my car, right? That's happened before. So this would give me flexibility and options. If I went to a hotel, I could stay in any room they had available. So I'll tell the client, why don't you start with like the 3rd floor? And then the next trip, the 5th floor, and then the next trip, the 9th floor. And if they come in session, we'll go across the street. I work right across from a big mall. We might go up on higher levels at the mall and kind of, just kind of overlook the railing. what it's teaching the person is like when we do that, they're saying, you know what, I'm doing it, Chris. We've been standing kind of, on this third floor balcony for a little bit, and the urge to jump off has kind of faded. The initial urge was scary and I wanted to bolt, but when I really stuck it out and stood on here and had a conversation with you and enjoyed the view, my anxiety and went down and my clarity went up, and I don't want to jump at all. And if we do enough of those exposures, people start to collect data, and then it's like, well, what can you conclude? I conclude that I don't want to jump off of a high building. I don't want to hurt myself. I actually really do like my life, and I accept that life has ups and downs, right? And the only reason I've ever felt I was going to harm myself in the first place is because of OCD. So you know what? I'm not going to listen anymore. So when OCD tries to talk to me, I'm just going to tell OCD, like, you could be right. Congratulations. Thanks for being here. But I'm going to go back to what I'm doing. So that would be an example for that question. Stacy at 1239 says, I have OCD and eating disorders myself. For me, it's being fixated on the perfect number on the scale and then on the number carton. ERP is what helped me with the eating disorder and OCD as well. Working regularly with my OCD specialist, I feel BDD is definitely involved in being perfectionistic. I'm so glad you'll be focusing on that topic. Yes, like I said, it'll be in February, which sounds so far away, but it's not. And then I'm going to talk to the BDD special interest group about doing a live stream on BDD as well. I think both of those topics coming up today are important, but I'm so glad to hear that the treatment helped and worked. And there's a lot of overlap because there's sometimes where there's a lot of OCD around eating. Sometimes people have a fear that they're going to eat expired food or that they see something on the food. Sometimes with a emetophobia, they're going to eat food, it's going to make them throw up, and they're scared about that. So we see a lot of that, like OCD around food like that. There's an eating disorder and OCD crossover disorder kind of called orthorexia, where people fixate on healthy foods. I have to eat everything organic, dark green lettuce. I can't eat anything with fat or sugars in it. And so they avoid certain foods. There's people that regulate their food because of eating disorder and trying to change the number on the scale. With BDD, sometimes people have obsessions around food because they might not like their jaw, and they think that if they don't eat certain foods with salts and in it, that they won't retain water and their jaw will be sharper. So a lot of times with these disorders, we're figuring out what is the motive behind it, so we could get the person a proper diagnosis. Stacy also said that she worked regularly with a nutritionist or registered dietitian. Absolutely. If I'm ever working with a client that has OCD, BDD, or eating disorders around food, I always work with a registered dietitian. Nutritionist is so important because a lot of my clients have really false beliefs around food, and they're causing a lot of damage to their body. So you want to make sure that. At 1244, L. Allen asks, how do you separate the rational and irrational of contamination OCD? I'd say any OCD, right? So I always like to tell people that OCD shows up in certain ways that we can start to kind of determine that it's OCD. So what I mean by that is, no, OCD doesn't come to us in a different voice or with a different cadence, but it talks to us differently. It's very irrational. It's very urgent. So it yells at us. It doesn't let us focus on anything else. And it has us just kind of like tune out everything else important. And it's that loudness, that urgency. You have to do it right away. It's always catastrophic. Nobody ever comes into my office and says, man, I'm afraid I'm going to get a slight 2-day cold, or I'm afraid I might bump into someone's car in the parking lot. It's always like, I'm going to get a disease and die, or I'm going to hit somebody with my car. So if OCD is always catastrophic, definitely a sign that it's OCD. If it's very black or white, with contamination, if there's a little smudge on a couch, the whole couch is contaminated, or I can't go into any Target because all Targets are contaminated. So if it's all or nothing like that, that's a big part of it. With contamination, if your brain is tracking and acting like the contamination is moving around your house, or for me, like there'd be times I'd walk down an aisle at a grocery store and something would be contaminated in the aisle and I didn't even touch it. So thinking that the item is like jumping and touching or getting into your products, that's a way that you can tell. I always ask people, if you were to stand on a podium in front of 1,000 people and tell them about your OCD obsession, do you think all 1,000 would be like, yeah, no, I do that too? Or would people be a little bit confused or tell you like, no, I don't even do that? We don't want to use that compulsively, but that helped me a lot of times to ask myself, or to just observe, how come nobody else at the store is wearing gloves and wiping things down? Now, I know with COVID that's different, but my OCD was before COVID really bad. And it's like, I'd be wearing gloves at the store and wiping things down and nobody else was. So it's like, why do I have to live with a different set of rules than everybody else? A lot of times too is like, is the rational thought in kind of your make believe? I always call it the OCD story. So a client will tell me like, oh my god, something just happened, and I'll be standing next to him. I'm like, I didn't see it, I didn't hear it, nothing happened. And they're like, yeah, but it could have happened. So OCD talks about could haves, should haves, what ifs. So those are some ways to handle that. Thanks for the compliment, John. It's good to see you at our live stream. Debbie says 12:45. Does OCD cause you to have anger? Yes, yes, yes. So I did a talk with Liz McAville actually at a conference many years ago that was really well attended about OCD and anger, and I think we need to revamp it because it's important. I actually run a free family and loved one support group. It's available to anyone from everywhere. It's absolutely free. If you're interested, just email me. It's my name at or actually I'm trying to think the best way. Yeah, just email me. It's my name at gmail.com. You could do my personal. So it's christronson@gmail.com. But I'm running a family and loved one support group. It's free, but we're actually talking about this topic this weekend with 2 local clinicians. So it's a great free resource. You can come, just listen. We have about 100 families. You don't have to share. It's one of those you can just listen in on the presentation, ask questions. But we're talking about that because there's a lot of anger with OCD. There's anger at family members, there's anger at the world, there's anger at life. We just get so agitated. Once again, I was talking earlier about that emotional dysregulation. So you got to remember is that with OCD, our emotions are very intense. So when we feel happiness or sadness or low moments or anger or guilt, we feel it much stronger. So we're going to feel anger a lot louder when we're triggered than other people. We're going to get very angry at people in our environment. Why did that person from the store just walk in and smell? Why did they bump into me? Why did this kid have to come by me? Like we get mad at the world instead of mad at the OCD for making us be scared of the world. A lot of times family members and loved ones do things in the house that trigger us. They don't answer our questions the way that we want. We're tired a lot because our brain is constantly overworking and our sleep is dysregulated. We don't always eat well because of OCD, because we might have obsessions around food. We don't exercise because we might be triggered. So there's a lot of factors that come into play. We're very short-tempered, we're irritable, we're frustrated, our bowl is covered. So I remind family and loved ones that, look, people with OCD aren't bad people. They're not angry people, and they're not hateful people. We're just under attack all the time. And you have to remember, when we're in that fight or flight panic mode because of OCD, our brains don't prioritize anything else but getting to safety. And unfortunately, the way that our brain works is the way that we think of safety is to do our compulsion and to kind of bolt from that situation. So until we can bolt and feel safe, we're very triggered, we're very irritable, we're very short tempered. So the good news is it's not some permanent damage that we're going to be angry forever. What helps, obviously, is getting better from OCD and the tools. And one thing that helped me is just taking a deep breath. It sounds like a very small thing, but I would be triggered by my mom. We'd have to carpool up to treatment together, and she'd do things in the car that would trigger the OCD. And I'd get very frustrated, and all I would do is take a deep breath and blame OCD because it's always OCD's fault. It's not my mom's fault. It's not my fault. And I would almost swallow my anger, kind of sit and cool myself down. So definitely something. I'm glad you asked the question because it definitely impacts a lot of people. But like I said, the treatment helps regulate your emotions. And I know that all the anger I used to feel when I was severely suffering, when I had tools to get better from the OCD, that really, really helped. So Matt also talks about at 12:46 exercise helping with depression, anxiety. Absolutely. Our brain releases endorphins, which are a natural Prozac. We burn off some of that, those neuropinephrine, that cortisol, that stress energy. We burn it off in aerobic exercise and weightlifting. And it really helps with anger. I know for me, when I'd work out afterwards, I felt very cooled down. So that's really, really good. Question right there. A lot of people seem to be dealing with anger. So that sounds, super, super something that everybody's dealing with. Susie at 12:48 says, as a parent, how can I best support my child with OCD? So for example, do I continue to remind him that we are waiting to leave while I know that reason for him taking the time is because of his compulsions, or do we wait and not say anything until he's completed? Also, do I not confront him in the moment? For example, noticing that he is opening cabinets without touching his hands, or do I leave it and discuss it at a later time? I'm going to put my email. This is my work email, so I'm going to put that one in the chat. That's probably better than my personal. I'm going to put that in the chat for Amanda to share. So Susie, like I said, we have a free virtual family and loved one support group every second Saturday of the month. Definitely email me and I'll go ahead and give you the link. So it's ran by myself and my mom. We have guest clinicians. Some of them you might know from live streams. We've had Liz, we've had Tommy, we've had Ethan, and we've had Katie. But we talk about this in depth. And so the thing that we always talk about is the best thing to do, Susie, is to have a meeting. If your child is seeing an OCD specialist, have that meeting during a session. Or if they're not in treatment, have a family meeting, not at the moment of fighting, because this was one of the things. So in my family, I was always late to family events like Christmas and Thanksgiving because of OCD compulsions. I'd be like 8 hours late. And the family was very hostile and angry because they'd wait till I got there, but the food was cold and people were sitting around. So what you do is you have a family meeting when there's no stress. You sit down and you say, okay, this is not your fault. We know it's the compulsions and OCD, and you're working on that and getting better. And the fact of the matter is it's making us late. And we're getting very frustrated because we need to go and it's making us late. So we got to create a plan now that we can enact when the moment arises. So if it's in the morning to leave for school, if it's to go to a doctor's appointment, a family event, etc., what would be the plan? Getting them up earlier, timers, doing things the night before, etc., until you can get to a point, obviously, where you work on the exposure and then they're dropping the compulsions. You create that plan in that meeting, whether it's with a therapist or if you're not with a therapist, like a family meeting, and you come up with those different scenarios that can arise. And you make sure the person with OCD joins in so it doesn't feel this attack against them. It feels like a very kind of like open dialogue and discussion. And then what you would do is you would ask them, like, when this is happening tomorrow, do you want warnings? Do you want heads up, etc.? You plan, what do you do if the person isn't ready and you need to leave? What I tell family members is pick and choose your battles. If your family is going to go out to eat and your loved one is keeping you late and you have reservations and you made a plan and you're acting the plan just like you planned, and the person with OCD is not following along and they're running late, you guys go to the restaurant. They can either meet you there or they can stay home. Sometimes you have to have a babysitter or a family member on call if they're young, and you go and enjoy the food. You may have to give in to more compulsions and stuff if it's a doctor's appointment or something super important. But my main thing is make sure that you make that plan ahead of time. You work with a therapist to specifically focus the treatment on their routines to get them out of the house. That can really help. And then ask them what they need in the moment. I wanted my mom in the moment, if I was doing compulsions, to remind me to snap out of it so that I could do the exposure response prevention. Some people don't want to be reminded, but what I'd suggest then is later that day when they've calmed down to remind them, hey, earlier today, you were doing compulsions and it prevented us from leaving on time. What are we going to do differently? So hopefully that helps, Susie. And if you can make it to our family group, that would be great. A lot of people talking about anger. So that's super important. We have a couple more questions. I'm going to try to get to them quick. So we have Kid Yao at 1253. Is crying a compulsion, especially with pure O? Pure O is individuals that have all mental obsessions and mental compulsions. So it's technically pure OC. It just happens to be in your head. Is crying a compulsion? I wouldn't say crying is necessarily a compulsion. It could be. I mean, anything could be a compulsion. The times I've seen crying as a compulsion is if people have intrusive thoughts about like harming a family member. They feel good if they cry because it's proof that they don't want to hurt their family member because I'm crying and worried. Therefore, I can't be a bad person. But most of the time, crying is just more so a result of being emotionally drained, that emotional dysregulation and stuff. So what you can always ask yourself, Kid Yao, is what is the purpose behind the crying? Is it you're just crying because you're tired of the thoughts and frustrated? It's happening natural. Don't beat yourself up. OCD is a horrible disorder, like you said in your next comment, and it's going to make us cry at times and be frustrated. But if there is crying, like I said, sometimes people with intrusive taboo thoughts will cry because it's like, oh, see, I feel good because I cried. Therefore, it must mean that I'm not a bad person. So you always want to kind of ask yourself. You're saying that crying makes you feel better, though, and your anxiety goes down. Once again, if you're not trying to cry and it just happens to make your anxiety go down, you can't control it. That's okay. All right, last question. My husband is afraid, it's at 12:59, so right now, my husband is afraid of herpes and did research on it. 70% of the population has it. So yeah, there's two viruses. There's number one and number two. Number one is like cold sores. Kids get them. And I think the population is even higher. I think it's like 90% at a client with this. We looked it up. He is trying to struggle with the rational and irrational, especially if herpes labialis. I don't know if that's herpes virus 1 or 2, what to do. All that researching is just going to make him more confused. It is okay to do assurance, not reassurance. So, what I've said to clients with this obsession, go to a doctor, bring your questions once and only once, and ask questions, because your husband doing research, he is processing information on the internet, not coming from a science medical background. And I, like, for myself, I have access to journal article portals that the average person doesn't. So, I'm going to be able to get peer reviewed factual data that people can't just access from Google. So a doctor is going to be able to answer his questions from a doctor lens with factual information. So what I tell clients is, if you have something like a cold sore or herpes 2 virus that 90% of the population has, go ask your questions once, normalize it, and then leave that meeting and recognize that anything you do differently from the instructions from the doctor is the compulsions. Don't make a second appointment, a third, a fourth, and drop that research. So yeah, if you get herpes, it does last in the body forever. People get cold sores throughout their life. If it's herpes 2, I think, I don't know a lot about this because I'm not a medical doctor, but herpes 2, it's in your system forever. I think there's breakouts or not. So the treatment is if he does have herpes 1, let's say he gets cold sores, the treatment is to accept that. Acceptance is just simply acknowledging fact. It doesn't mean you like it. There's nothing your husband can do. Go to a doctor's once, get factual information, and then move on. There's nothing else he can do. That's what the compulsions lie to you about. It's like, if you just ruminate about it, if you fixate on it, if you do these compulsions, you'll get clarity, you'll be able to fix it. Look, there's researchers out there for decades that have researched this medical condition and try to create a cure for herpes and haven't. So unfortunately, your husband is definitely not going to cure it by Googling and researching. So I guarantee that if he drops the compulsions, he accepts the fact that he does have herpes and he doesn't have symptoms right now, but he may, and he moves forward taking any precautions from that one doctor's appointment, that will get his mind into a rational mode, and then he'll be able to drop the irrationality, because researching all depths of the internet is not going to get him any answers or make anything changing. So hopefully that helps. If it didn't answer enough, please come back to our next live stream next week, the 14th, and we'll be able to answer. Oh, actually, the 14th is Research Roundtable, but the following, the 21st, definitely come by. Go to iocdf.org/peace of mind. That's the entire schedule of future live streams. You'll see Ethan's community conversations. You'll see, I think it's Dr. Davis who's running the diversity roundtable. We have research roundtable with Kyle and Dr. Abramowitz. So check out that schedule. But the next one, if you come back, Alan, will definitely make sure to answer that question more in depth. But hopefully I gave you a start. All right, so from some final things is definitely, like I said, iocdf.org/peace of mind. Make sure that you head over there to get the full schedule for December and the upcoming live streams. If you missed some of this live stream, or if you've asked questions in the past, or you want to see past live streams about topics, if you head over to youtube.com/iocdf, make sure to head over there. You'll definitely have an opportunity to catch up on past live streaming. And then make sure to go to iocdf.org. That's for general information. Deidre asked for my work email. If you could put that up one more time, Amanda. If you are a family member or loved one, please email me. Like I said, this Saturday and every second Saturday of the month from 11 to 1, I run a free family and loved one support group that you and your family can come and get resources. So definitely email me for that, or if you have any questions. So the next family group is this Saturday, December 10th, from 11 a.m., 1 p.m. Pacific Standard Time, and it's every second Saturday of the month. There's also a really good live stream from Ethan on the IOCF's YouTube, where he does his live stream, his keynote, and he talks about family, about how his family helped. Also, my mom and I were the 2011 keynotes, and our keynote is up on YouTube, the IOCF's YouTube, and there's a really good, it's by my mom and I, so we talk a lot about family stuff. I know there's a lot of family conversations at the IOCDF's conferences, so make sure to head out to those. There is our kids camp coming up in the first weekend of February. The IOCDF is having, so it's a time for parents and for children to come and get information on OCD. So there's a lot of really good resources. The two books I like are by John Abramowitz and John Hirschfield, and they're both about OCD and families. So look those up as well. So there's a lot of great resources. I want to say lastly, thank you to everyone that comes. I don't think I say it enough, but I love the OCD community. I love everybody that came to the live stream today and asked questions and supported each other in the chat. Thank you so much for being here. I'm here with Liz every first, second, and fourth Wednesday. And if there's a fifth of the month at 9 a.m. Pacific, 12 noon Eastern. And like I said, iocdf.org/peace of mind if you want to hear about all the other great live streams that we have as well. Thank you so much for joining us today. Hopefully I answered your questions. We're going to have a psychiatrist in January, so we'll answer those. We have a couple good topics coming up as well. And I got down all the questions, so we'll be answering them each week. Come back and hang out with us. And thank you for spending some time with me. I really appreciate it. Take care, everyone. OCD sucks. Never forget that, and it always lies. And iocdf.org is your go-to source for support and for help and community. Thank you, everyone. Take care and have a great rest of your day.